this initial period is to correct hypoxemia and to prevent ventilator-induced lung injury. We will focus on the most severe ARDS patients during this talk. What about the definition and the level of PEEP at 5 centimeters of water? In recent CT scan study done by the group of Luciano Gattinoni, they showed that 5 centimeters of water was able to discriminate the patients presenting mild, moderate, or severe ARDS according to CT scan lung lesions. As you can see here, 5 centimeters of water was more able to differentiate these different presentation of lung lesions as compared with 15 centimeters of water. Moreover, if blood gas were evaluated initially with a PEEP level at 5 centimeters of water, it was well correlated with mortality. And the severe ARDS group, for example, mortality was 70% as compared to 26 and 32% in the two other groups. Hypoxemia is related to mortality, and in this accompanying paper of the Berlin definition, it was suggested that mortality was a little bit higher than 46% in severe ARDS group, and this was confirmed in the recent LungSafe study. It was exactly the same number, 46% of the mortality in the severe forms of ARDS. The other objective is to prevent ventilator-induced lung injury. You know that there are many experimental papers and some clinical studies. I will first start by intubation. There are recent epidemiologic information suggesting that if you delay intubation, there is a worse prognosis. In these recent papers, patients never intubated were compared to a group of patients intubated during the first 24 hours and with a group of patients intubated after day 1. And the authors showed that there was an increase in the mortality rate when intubation was delayed. And if you use non-invasive ventilation or high-flow oxygen supplies, it's necessary to think to intubate the patients not too late. Regarding the optimization of ventilator settings, we have to remember that even if this study is 15 years old, we have the surprise to see that in our ICUs, more than half of the patients are still ventilated with tidal volume exceeding 7 milliliters per kilo. We have to reduce this tidal volume, especially in the less severe forms of ARDS, because it has been shown that the prognosis is worsened when tidal volume, high tidal volume are used even in patients presenting with low levels of blood pressure. Regarding PEEP adjustment, you know that the response to PEEP is different between patients, for example, with diffuse lung injuries assessed by CT scan or patients with more heterogeneous presentation. Comparing these two CT scans, you can see that on the left side of the slide, there was an important recruitment and re-aggregation related to the increase of PEEP. In contrast, in the patient at the right side of the slide, there is no improvement in recruitment, and PIP is increased probably over inflation. And this problem of over-distension, of hyperinflation, has been explored using PET scan, and as you can see on this slide, there was an intense inflammatory activity in well-ventilated lung areas, suggesting that these regions are submitted to distension. Increasing PIP is related to a better distribution of tidal volume, and it has been shown that recruitment is higher in the dependent part of the lung when PIP is increased. However, studies comparing the high level of PIP with low level of PIP have been negative, except for the meta-analysis of these three trials, which shows that for the most severe forms of LDS, there is probably an interest to use high PIP level. In contrast with patients presenting with the less severe form of LDS, high level of PIP are probably deleterious. The message is that you have to adjust according to individual factors of the patients. You can use more sophisticated tools such as esophageal pressure, but the very easy to interpret chest X-ray can give you some information. If you have diffuse lung infiltrates, probably a PIP will provoke an improvement in oxygenation, but resulting from an improved recruitment. However, when the results of the LungSafe study were published, we were surprised by the low level of PIP used in our ICU. This is the recommendation for the alveoli high PIP arm, and this is the recommendation for the alveoli low PIP arm. And you can see that when FiO2 is higher than 0.6, we use low level of PIP, lower than recommended in the low PIP arm of the alveoli study. Regarding the recently published driving pressure, it's an interesting tool to assess the importance of PIP setting and subplateau pressure. On the left side, you can see that plateau pressure is increasing while PIP is maintained, and there is an increased mortality. In the middle panel, there is still an increase in plateau pressure associated with an increase in PIP, resulting in a constant driving pressure. So you know that driving pressure is the difference between plateau pressure and the PIP. And this results in no change in mortality, despite the fact that plateau pressure increased. And in the right panel, there is no modification of plateau pressure. There is an increased PIP, and this results in a progressive decrease in driving pressure associated with a decrease in mortality. There is no perfect threshold. The threshold of 14 centimeters of water of driving pressure has been shown to be correlated with mortality in the LungSafe study. One interesting point in the driving pressure study done by Amato is that there was a strong correlation between driving pressure, especially when driving pressure exceeds 16 centimeters of water, and the risk of barotrauma. In contrast, there was no relationship between tidal volume and the risk of barotrauma. About adjuvants for severe ARDS, there is the use of neuromuscular blocking agents. We have shown more than 10 years ago that the use of cisatracurium was associated with an sustained improvement in oxygenation. But it is important to keep in mind that the use of neuromuscular blocking agent is associated with all the lung protective strategy, with a reduction in tidal volume, low plateau pressure level, and this is done during a short course. This is done early in the course of ARDS, and after 48 hours, neuromuscular blocking agents are stopped, and we try to maximize the use of spontaneous breathing when possible. The use of paralytics was associated with a better outcome. What about prone positioning? Claude Guérin has shown in his study that there is an improvement in the outcome when prone positioning is used in severe ARDS patients. I have to say that one major thing for practical issues is that in this study, prone positioning was used even if there was no improvement in oxygenation. We have to continue prone positioning even if there is no increase in PF ratio. And patients have a mean of 4 prone position sessions during the course of ARDS. And ARDS treated by prone positioning is associated with better outcome if long periods of prone positioning are used, if lung protective mechanical ventilation is implemented, and in severe ARDS patients. What about rescue therapies? Inhaled nitric oxide is a very easy technique. It can improve right ventricular function. It is very easy to start, but there are some side effects related, for example, to certain renal toxicity, related also to a rebound effect when inhaled NO is nitric oxide is stopped very abruptly. And it was shown that the longer is the duration of inhaled nitric oxide administration, the higher is the risk of rebound effect with an increase in mean arterial pressure and a profound hypoxemia. All randomized controlled trials regarding inhaled NO have been negative, but we have to say that this rescue therapy was not evaluated in severe ARDS patients ventilated according to a lung protective strategy. In some instances, there is still persistent hypoxemia with diffuse lung infiltrates, and it's possibly time to start veno-venous ECMO. But criteria have been proposed, especially for ECMO centers, when PF ratio is lower than 50, despite adjustment of PEEP, prone positioning. But in non-ECMO centers, when there is a need for a mobile unit, probably it's safer to phone to the mobile team when PF ratio is lower than 70. There is an important thing for ECMO, it is that the better outcome is observed for patients who are cannulated prior day 7. However, an important thing is that many patients are treated by veno-venous ECMO